I'm happy to introduce my next two speakers. You've all met Pamela Duncan, Professor of Neurology at the Stick Center of Aging, School of Medicine, Wake Forest University, and the Wake Forest Baptist Health. And Michael Johnson, Practice Leader, Home Health from BAYADA Home Health Care Division. And I also want to say both of these folks are members of the CoStar External Advisory Board. So I welcome you and look forward to your talk.
Thanks, Linda. So Mike and I are really privileged to talk to you about how we built a collaborative relationship as we are rolling out our intervention for the COMPASS study. And in the spirit of the PCORI theme and requirements, the COMPASS intervention has been built with multiple stakeholder engagement. And today we're going to highlight the engagement with home health. I just want to commend Mike and BAYADA Health Care and our local Representative Richard Hobson because they have truly been instrumental leaders as we've refined our implementation strategy as well as we defined our intervention. So it has truly been a collaborative partnership. And in fact, our first stakeholder group that we held last summer was with home health stakeholders representing national leaders from Kindred and BAYADA to local home health agencies with major health systems to your local county home health agency. So this was truly a collaborative effort. So let me just get you oriented for a moment before we start talking about this collaboration and our implementation is to what the COMPASS study is. The COMPASS study is one of the pragmatic trials funded by PCORI that I discussed last night, in which we are not randomizing patients, we're randomizing health systems to re-engineer post-acute comprehensive stroke services. And the primary aim of the COMPASS study is to determine the comparative effectiveness of this care delivery model versus usual care on the stroke patient's functional status at 90 days post-stroke. That is the primary outcome. And we obviously have a lot of secondary aims, including assessing the caregiver strain at 90 days, assessing all-cause readmissions at 30 and 90 days, and then looking at long-term integrated administrative claims data, look at mortality, healthcare utilization, and the use of the current transitional care billing codes through Medicare and claims at 1 year. So as I mentioned, it's a cluster randomized clinical trial. Hospitals are randomized, not patients. All patients who are discharged directly home are considered the denominator in this study, not just those who get the intervention. We are only stratifying hospitals by key characteristics as whether they're a primary stroke center or not, and their volume. The primary outcome is a stroke impact scale, which was developed many years ago, really developed from a patient and provider center perspective, and the secondary outcomes that I will mention. Now, what I'd like to do is give Mike a chance to talk about BAYADA and their home health services and their motivations for collaboration. Mike.
Thank you very much, Pam, and thanks for the invitation to participate. My PhD is a PhD in health policy. I'm trained as a health services researcher, but being on the delivery side, I would say I'm a very, very curious health services provider, which means I'm still a health services researcher. And so I'm glad to be here and talk about this collaborative. So, but I want to share a little bit about our organization because we're going to talk about partnership, and I think understanding your partners and their motivations is particularly important. So, BAYADA is a family-owned, mission-driven, values-based home health organization. We're in over 300 locations, 26 states across the country, and then in particular, the work that we've been doing with Pam is in North Carolina. Where we have 11 home health offices. We're clustered in central North Carolina. We're not on the far east and west coast yet. Served last year a little over 2,400 clients. Medicare certified, CHAP certified, but we also, a large portion of our organization is long-term care in the home, meaning private duty, home health aides, high-tech skilled nursing, and so we bring that to bear as well if that's something that the community needs. The next thing I think, so I was having a conversation with Julie in the hallway after their presentation, and she used the formula of value equals quality plus service over cost. And we use that equation when we talk to staff. But one of the things that we also add to that is there's a multiplier to that. And that multiplier is culture. That multiplier is culture, and you cannot underestimate that. And it was evident in the Intermountain presentation, for example, with the UPMC. There has to be this culture of collaboration and curiosity. And so we're fortunate that we are a independently owned organization with a 100-year vision. When you're thinking about how to be here in 100 years, you think differently than how to be here in a quarter or the next quarter. Our scope and scale provides us with opportunities, I think, to be a better and a more unique partner. And all we do is home health services. And so we have over 800 partners in SNFs and hospitals and physician practices that we're working with to figure out how to do this better. I will tell you, we don't have the absolute answer, but we've looked at it 150 different ways, and we've got lots of good questions. And so partnering with folks, that's where the magic happens. So let's shift then to with regard to the collaboration, the partnership that Wake Forest Baptist and BAYADA did. Some of the drivers for that is there's a lot of incentive for collaboration. We say oftentimes payment drives performance. So CMS has added reimbursement codes for transitional care management, chronic care management, complex chronic care is coming. They've started to report publicly admissions specific by diagnosis, such as stroke. And we certainly expect additional bundle payments, much like the CCJR, the Comprehensive Treatment for Joint Replacement. That is there's no opting out. Everybody's opted in. So we see that coming on the horizon. And from the home health side, less than a year ago, CMS changed the way that they did our public reporting and collapsed the data into star ratings. So we now, as of July, we get rated on 0 to 5 stars for quality, and then this fall they added the client experience star. So there's actually 2 stars. And they've also implemented a value-based purchasing pilot in a number of states, 5 of which we have offices in. So there's incentives to collaborate both on the payment side and potentially on the loss of payment side, or at least loss of reputation if you think stars are going to move that needle. So let me take a minute and just sort of paint the ecosystem as well more broadly, and it's a review from OSU. But the models of payment and the models of care are changing. Right, so bundle payments, payment influenced by patient outcome, encouraging care coordination, all of that stuff, and our previous speakers have done a nice job lining those up. Bundles, for example, different bundle models, and so we've been involved in a number of the Model 2 and particularly the Model 3 bundles. I will put a plug in from the standpoint of home health care, as I would ask you not to think of us as a post-acute provider. We're happy to help when they've come out of the hospital, but we can intervene before they go in the hospital to decrease admissions, and not just readmissions. And so when we're thinking holistically, that's a framework that I think is important. So then let's go a little bit more down into the details here with regard to patients with stroke, and then I'll hand it back over to Pam to talk a little bit more about the Compass project. So we know the needs for patients with stroke are significant. 24% readmission rates in the first 90 days, high rates of falls, and a much higher percentage of those patients tend to fracture their hip, and we know what the outcomes of that tend to be. Surprisingly enough, their basic functions that should be controlled, like blood pressure, are not in most cases, which is terrifying to think about. And the ability to take good care of them in facilities is much better than the ability to take good care of them outside of the facilities. There's additional challenges. And poor medication adherence and other challenges, other social challenges that these patients face require not an individual organization to try to figure it out. That is not going to work. It requires a collection and collaboration of organizations. So finally, and then I'll hand it back to Pam, just again, let's look at the ecosystem, the home health population for patients with stroke. Now, nationally, in general, stroke is one of the leading causes of death. We know that, and a leading cause of serious long-term disability. In North Carolina specifically, it's the 4th leading cause of death. Significant racial disparities, and North Carolina is considered part of the stroke belt. If you look at geomapping, North Carolina and that section of the country comes up. And in fact, if I remember correctly, Pam, not only is North Carolina part of the stroke belt, it's oftentimes, or parts of it are referred to as the stroke buckle, meaning even a greater percentage of people there. So we know the need is there. And if you look at the home health population with stroke, and this isn't just North Carolina, but broadly, we see somewhere between 12 and 1,500 clients annually with stroke. For us, hospitalization rate for those clients in the first 30 days is about 18.6%. On average, and the range of this is huge, on average, they're taking 15 to 17 medications. Just the thought of that makes me feel like I'm going to have a stroke. Because the impact and the interactions, if you're setting these people up for failure. The other statistic, and these weren't on your slides only because I wanted to make sure this data was as accurate as possible, so I didn't have it on before the deadline, not that it's proprietary. But I added the mix of payers as well, because in my world, that's important. And the reason it's important is not specifically because of how much they pay or don't pay, but the regulatory hurdles around pre-authorization and so forth that come with managed care and commercial payers makes it much more challenging to get out to those homes quickly and deliver the level of service that we think is necessary. So you do have to think about the payer as well. So hopefully that gives you a little bit of a brush about BAYADA and leads us into the opportunity that we have in taking care of patients with stroke. So I'm going to turn it back over to Pam.
So thanks, Mike. And so why stroke? Because, again, it's another disease-specific condition. Honestly, we've treated stroke in this country as obviously a medical emergency. We have re-engineered over the course of the last 25 years acute care practices to manage stroke. You are basically not a competitive healthcare system in the country if you're not JCO certified in stroke management. And we've done it for 2 to 3 days of care. And in reality, stroke is just another complex comorbid condition. And it's really rare that stroke occurs in healthy individuals. So stroke is just another symptom in the complex comorbid state of an individual. And so we also truly believe that the things that we learn here will also be generalizable to other complex conditions. With this re-engineering of acute care, patients are really satisfied. They get immediate attention, and they get pretty much escorted to the door. And whatever happens is highly variable, and the patients are not happy. So as I mentioned last night, we did a lot of qualitative research to understand the challenges that patients were facing. And here is one of the most important voices, a 60-year-old white male living in urban North Carolina, member of the business community, and actually on the board of directors of the hospital, a highly educated, affluent patient. After the stroke, I had new prescriptions. I couldn't dispense my medications into daily doses. This math deficit was not recognized until I got home. I lived alone, and I had to take care of myself, and I was unable to cope. And guess what medicine he was on? Coumadin, high risk, and he can't regulate his doses. And then we also see, as I mentioned last night, from Janet Freeberger's work at the Shep Center. And Janet, I want to acknowledge her, and we'll be acknowledging her repeatedly today, has been a major architect of this study and this intervention. But Janet's work has driven us, too, to say, look, therapists are underutilized in the first 30 days after patients are discharged home in the presence of evidence that utilizing therapists appropriately can reduce hospital readmissions. And so we have not had in our healthcare systems very systematic ways or integrated management of patients once they've gotten home. And as Mike already mentioned, we now have major incentives to build care integrated across a continuum to optimize care, that we use the current advantages of the 5-star quality metric rating to look at the processes of care. Did you have timely initiation of care? drug education on medications provided to the patient and caregiver, and also did the patient improve their outcomes. Now, I didn't put in this slide, but if you go to the homehealthcompare.gov ratings and you look at the proportion of patients who improve function in the home health industry, it's not very good, about 50%. So the home health industry itself is under tremendous assault because, as in populations, we don't see a great magnitude of shift in the patient's functional status when they get home. And so how do we begin to partner to develop the processes and structures of care to make it work? So what is Compass Transitional Care? And I want to tell you, it is very difficult to define. This is not one single bullet of let's get the physical therapist to do balance training. It's a very complicated, engineered product with very structured processes and methods to capture our processes and ultimately to measure our outcome. But first of all, we are using existing reimbursement models with healthcare systems, the billing codes of transitional care management, and we will eventually employ chronic care management with the patients. And what we do is, rather than that patient being shown to the door and saying, I hope you can fly, and there's a tremendous variability of service out there, and oh, by the way, we really didn't capture what your functional deficits were when you were discharged. We have incorporated early supported discharge assessment by a nurse practitioner within 2 to 7 days of the stroke. They come back to see us, and there is also a nurse that works with the APP to implement the standardized assessment and to collaborate and develop the care plan. Very standardized, very structured. We also are building collaboratives with the home health, outpatient, and community-based service organizations. So they are members of our team. And as we've introduced our evidence-based processes and pathways of care, they've been partners in developing those, and we are now, as of last week, going out to every site-specific hospital community and bringing these providers to our table to understand what the processes are for care and what we collaboratively would like to deliver for the patients. And tomorrow morning, I will be in Pinehurst First Health System to deal not only with the hospital providers, but with the home health providers, with the outpatient providers, and the Area Agency on Aging. So this is a part of the process. And most importantly, we are going to use a common language. And the common language is that everybody is going to get an electronic care plan based on the patient's functional, cognitive, and social determinants of health. That care plan is developed on that 7 to 14 day visit, or we see the patients within 2 to 14 days visit. And that care plan follows the patient, and the patient also selects in this care plan what their priorities are. So the important part of this pragmatic trial is that we're not paying these health systems to be part of this trial. The only thing that PCORI has allowed us to pay is actually a basic case ascertainment fee, as well as additional support for some of the capture of the data in the ongoing practices. So what we will do is address the needs of the stroke survivors, all those patients going directly home, not those who go to SNF or inpatient rehab. And believe it or not, in stroke, that is the group of patients who have the highest rate of readmissions, not those who go to SNF or IRF. As I mentioned, we'll connect the hospitals, the community providers, and each community provider hospital with these structured processes will have to implement within their healthcare system, and the most important part of this is this individualized care plan. Now, the point is, know that patient. And as you have heard many times this morning, and as you read many times in healthcare, we capture these measures, but what do we do with them? And does it immediately inform the patient's care? So we have integrated in real-time practice and electronic capture of functional assessments that immediately after the patient is interviewed, in this case as stroke providers, as stroke patients with the nurses, immediately generates a provider report that says, oh, by the way, you know what? This patient can't afford their medicines. Oh, by the way, this patient's on 17 medicines, and they don't have the cognitive ability to manage the medicines, and they don't have a person at home to help them. That report is generated before you see the advanced care provider. She looks at that report and then internalizes that data with the patient as she develops the care plan. And then she has the right, after her assessment, to override or support that, and then the patient and the family also have engagement in that report. Now, what we've done, CMS is just spewing requirements. I didn't say that publicly, did I? So if you go to the CMS requirements for chronic care management, transitional care management, they tell you, oh, by the way, you better know these 15 dimensions of the patient's health. What's their cognitive status, what's their social network, what's their transportation, what's their physical function, what's their financial resources, and you're supposed to do it in a 20 to 15-minute visit with the primary care. It is not going to happen. And you know what? It's not going to happen if you put physical and occupational therapists in the sites unless we set the mechanisms up to do it efficiently and effectively. The Institute of Medicine has also made recommendations that we integrate social and functional determinants of health in the processes of care. So all that we've done simply, and I'm not going to get into the details today, is to take all those spews from CMS and the IOM and made it pragmatic. It can be captured and it can inform the care plan in real time. Now here's an example. Once we have assessed the patient, we have developed with patient, stakeholder, providers, policy input that we're all going to message the same thing to patients. Compass, finding your way forward for recovery, independence, and health. And in that message, you have to follow the 4 directions of the compass. Every provider is to message the same. The most important thing after stroke is know your numbers. Blood pressure, blood pressure, blood pressure, blood pressure. And every provider is to message on that and have similar messages and processes for management. And we also, if they're diabetic, to hemoglobin A1C, and certainly if you're on warfarin, your INR value. So everybody knows their numbers. So if the patient, we assess what their blood pressure is, it's out of range. Why is this important to you? Do you know that when we interviewed patients, they knew they had high blood pressure, but they didn't know that blood pressure caused their stroke? Why is blood pressure important? And then what do I do about it? So in every dimension of the compass, we have, why is this my concern? Why is it important? And what are my options to do about it? Parallel with that, we have also integrated by county in the state of North Carolina the resources, the community resources that are available for patients and caregivers to manage themselves. And a prime example, 99.9% of frontline healthcare providers don't even know what the Area Agency of Aging is in their community. And how do we bring to the forefront those resources for stroke patients, for chronic disease management, as well as caregiver support, as well as support for home assistance? Now, this requires bringing all the partners together. On our Compass team, we have every discipline and every entity represented as we've developed this. We have primary care represented, community-based services, pharmacy, home health, outpatient rehab, and the hospital stroke teams. And at the center of this, it's all been guided by the patients and caregivers, and they're involved in each step of the way. And if I can say to David while we are moving forward, this is a lot of effort and takes a lot of resources to do this, to do it right. Now, what are our expectations of partnerships? We establish those in the very beginning. And we go to home health agencies and we said, you want to partner with us? You need to take this as a priority in your community to work with us. And you need to dedicate a PT and our RN to be the agency champion for COMPASS. You need to be, as part of this partnership, to communicate with our nurse practitioner and post-acute coordinator. And it will be important for you to provide this individualized care plan in the home, provide us feedback with things that we may not have captured in the outpatient visit. And guess what? We went to Atul Gawande's plan that we would have checklists for the home health agencies. It's not as prescriptive as you think it will be, and we need you to provide us a monthly list of all COMPASS patients treated by your teams. And to be part of this team, these are the things that we need to work and share. Now, parenthetically, Pam Duncan, Truth in Lending, we're out in the field. We had our first 3 site visits, and isn't working as pretty as we'd like. Now, I got to deal with it on Friday, and I'll try not to send a Pam Duncan email, if any of you have ever received one of those. But one of our biggest invested partners in our site-specific visit sent their sales team. Not acceptable. And you know what my message is going to be? You're not going to get our patients. We're not interested in your sales team. We're interested in your frontline clinical providers. This is a challenge, right? Not BAYADA. It wasn't BAYADA. We also do train the trainer model. And again, Richard Hobson has been a major architect in this. They are making a commitment that we have provided. We have spent a year developing all the resources, and again, Janet Freeberger, Amy Pastava, Karen Taylor have developed all of the training modules, developed the orientation planning, constant feedback, and here are the modules, here are the expectations, now you make it happen. And the other part, as we roll and start enrolling patients in August, we will have twice monthly conference calls with our home health and outpatient therapy providers to see how it's working. Here are the basic guiding principles of COMPASS. It's really to orient and develop partnerships with agencies and outpatient services for comprehensive stroke care management, and that we have guiding principles. First of all, stroke survivors get better. And it's not a marathon, as Mike said. I mean, it's not a sprint, it's a marathon. It's not just 1 or 2 visits. That recovery across all 4 directions of the compass has to be our common message. And that our ultimate goal is that we are not paternalistic, that we are at every stage of the way preparing the patients and their caregivers to self-manage. We immediately link them to what resources and exercise and falls prevention resources are available in the community. And we're integrating medical and social services. And the most important thing is know the patient, know their function, know their social determinants, and know their goals. And in this realm, don't forget the caregiver. So again, as I've mentioned already, how do you get something that will stick? And what we've done is we've said, here's the compass. And this is plastered across all educational materials at every level. Finding your way forward for recovery, independence, and health. Every provider messaging on knowing your numbers, engaging physical activity, engage your mind, ask for support if you need it, and are you willing to manage your medications as well as to adhere to lifestyle choices. Now, you can't read this and we will send it, but this is the home health and outpatient provider checklist, and this is how we expect you to work with us, and they expect us to work with them to provide the e-care plan, electronically accessible to all providers through our link. Here's how we would like you to message on blood pressure management. And again, I want to be critical of physical therapists. do you know that one of our biggest barriers when we brought the leaders from the home health agencies in place, the national leaders, do you know what they said? Our biggest challenge is managing physical therapists. Because physical therapists want to do what they want to do. You don't have that problem, do you? So Pam, yes, we'll come to the table, set the structure and process that, as Gerard said, there's variability, but there are certain things that you have to do. And in our own frontline healthcare system, when Susan Reeves went to her frontline physical therapy outpatient staff and said, every time a patient comes in this door with a stroke, you will measure blood pressure. No, that's not our responsibility. Well, why not? Right? Now, these are really basic things that we shouldn't be messaging on to professionals, but it's the real world. And then we have whole strategies for managing medication, and again, we've aligned that with the quality 5-star quality initiatives from home health. And we have, and this is very important, and with Janet and Amy's leadership, we have an entire message, movement matters. And what are the characteristics of the therapy services that you should expect? The evidence is overwhelming without any scientific doubt that if you improve strength, balance, and cardiovascular endurance after stroke, you not only improve their immediate outcome, you improve their quality of life. But it has to be structured and progressive. And we're also messaging to patients. These are the questions that you should ask the therapist when they come in. Are you challenging me? Are you working on my strength, my balance, and my endurance? So that's the checklist. And I want to also come back to this concept of engagement. I don't think any one of you doubt my passion in here for changing stroke care. It's not going to get us anywhere. And we didn't sit in the lofty towers of academics and say, this is how you will do it. We have engaged at every level of the way. And we engaged our patients in terms of even how the e-care plan should look and how they wanted it messaged. We engaged frontline practitioners. We brought the Janet Freeburgers in the world to the leading health services researchers. We brought the Amy Pastava, who, by the way, doesn't have a history in stroke, but is one of the leading experts in exercise physiology. We brought the leading people in outcome metrics. But at the end of the day, if it isn't messaged to the patients with what their goals are, it's not going to work. So a lot of our resources in developing this has been in patient engagement. So that's the big picture, and I'm going to turn it back over to Mike.
So thank you, Pam. So what I'm going to try to do as I start to move us towards a close to make sure we've got time for the questions and answers, because we can't get into nearly the level of detail of all the things that we worked on, was to highlight a couple of things. One, at sort of a granular level, how do we roll this out? And then sort of at a macro level, because I think the context is important to sort of wrap up. But Pam touched on this a little bit. For us as an organization, it was important to know that what Compass was looking to do would also help drive what CMS is expecting us to do. And quite frankly, what we expect of ourselves. But so alignment with promoting client satisfaction. This whole process, I can't believe clients are going to be more satisfied. And from a star ratings, that can only help us. But more importantly, it helps the clients, as well as value-based purchasing. So you saw the slide earlier. There's significant overlap in the things we're being measured on and what the Precori Compass project is looking to do. And so that alignment is really important. And really, our expectation of Pam and Pam's expectation of us is that to be a partner, a preferred provider, you've got to shut up and put up. And the data will do that. But you have to do it sort of in a nice way. So I'm here to publicly state, at least to this moment, I don't know that I've ever gotten a Pam Duncan email, and I hope I never get one. So some of the nitty gritty, and these slides Richard Hobson helped put together, and unfortunately he couldn't be here because he can really talk about the details. So if you're interested, I can connect you. But a couple of things to think about as a provider when you're sort of training your teams for this, because it's all about getting people motivated, excited, to do things differently than they might have, to do them more consistently, and to be held accountable for it. And how do you do that and have them come back and say, hey, thank you very much, this was great? So one is, first of all, you've got to feel comfortable that you know the clients that you're dealing with. So the identification is important because if the patient is Dr. Smith and it was a total hip replacement, what's funny is Pam's comment about therapists like to do what they like to do. That's true, but when you got a protocol for a total hip replacement, boy, you followed that protocol. We never questioned it. Because if you didn't, you'd never see that patient again. Well, we're basically struggling with trying to say the same things to ourselves. But so you need to know the patients. You need to have a core team, so a champion, somebody in that office, in each of our offices, who loves taking care of this population and will be the champion for the rest of the folks. It can't be me, I'm too far away. And so identifying people that have really a passion for this. And then a lot of work around clinical, the preparation for that team. We had pre-launch meetings, a lot of initial education, a number of things that we went through, got people familiarized with health coaching, the motivational interviewing that was talked about before. But one of the things in the e-care plan and the checklist, so everybody understood what the rules of the road were and why. But the other thing is, aside from the learning modules, these bi-monthly calls that Pam is mentioning is important. To me, that's sustainability. Set it up and then never sort of touch base again, and it's doomed to go in the direction that you don't want. And so that hardwiring is important. The other piece I want to point out is the idea of knowing how we're doing scorecards. Right? And so the scorecard, I was thinking about scorecards when Gerard was presenting, but standardized reporting and data metrics. So for example, what's the goal? Reduce rehospitalization for a population, that's the goal. We call that a lag measure because you're not, an individual clinician, it's hard for them to move that number, but then what's the lead measure, the thing you can do every day with every patient that will move that number? In this case, call it intervention for education given, medication education given to all clients, and then be transparent about it. So here's an example of a scorecard we have. So the driver, the lead measure that we know will help drop readmissions is this patient caregiver drug education, was it provided? In this case, 96% of the time. That's good, but it should be 100%. And we also track readmission rates by month. Not only do we get the rate, we actually give the actual number of people. Because we find for clinicians that has more meaning. 3% isn't the same as 30 people. 30 people, it could be my uncle, my aunt, my whatever. And so that piece, and then on a broader level, we provide and have for a long time a partner progress summary report that basically says, hey, here's how we're doing. And if we're dropping the ball somewhere, let's talk together about how we can get better at that. And so in there, we have drivers. So here, for example, is what percentage of the time do we get into that patient's home within 48 hours? Yes, it's a process measure, but it is an important driver for the outcome measure that you want, in this case, which is reducing readmission. As well as some of these others you can't read, but the patient caregiver medication education, where heart failure symptoms addressed, and where falls risks assessed. So things like that. And then secondary goals, improved ambulation and so forth, and sharing that broadly with folks. So that kind of transparency and learning together and recognizing where we're doing well and not doing well are important. All right, so I'm going to bring this to a close with sort of a high level in about 60 seconds to 120 seconds, because you've all heard this before, but I want to go back to sort of why are we here, what are we being asked to do? So the triple aim was built into the Affordable Care Act, and now it's called the National Quality Strategy. We all know what that is, right? Better health, better care, affordable. But that's easy to say and hard to do unless you got integration, right? Not co-location, as I heard earlier, but integration. And to me, that's really simply a matter of unification. And there was work done by the IOM, a report called Primary Care and Public Health, exploring integration to improve population health. It's a really nice report. And so there's this continuum of integration and necessary actions, shared goals, which we certainly have with Pam's group, a willingness and ability to contribute to that goal, and a commitment to an ongoing process and continual dialogue. That takes much more than clinical competence. That takes leadership competence. And that's the piece that I think we've been trying to infuse. So for us, we've been working long and hard at keeping people safe at home, and we've developed programs and so forth. But historically, because of how we've been paid, they're still silo. We're really good, we think, in our own little silo, but silos are no longer going to be are not going to help us take care of patients across populations. And so there's really this need for accountability across community-based systems. Accountability for overall health means coordination and integration. So we've got people in their communities. We've got the physicians at patient-centered medical homes and the institutions that are there to care for them. We've got the family caregivers. And then you've got this collection of neighbors, right, who are, again, co-located. The question is, are they integrated? And what Compass is trying to do is connect the dots, right? Because you need neighborhood engagement. If you get that, I call this the patient-centered medical neighborhood. And if you have that, this really, to me, is the answer for true effective population health management. But integration requires a level of leadership competency and a level to look sort of beyond yourself. And if you do that, then to finish this sort of corny example, you create a patient-centered medical neighborhood watch that keeps people sleeping in their own bed at night, which is where they want to be. So a couple things, and I'll go through this because I want time for discussion. I call it how to recognize a good neighbor. Community engagement, aligned leadership, I can't emphasize that enough, shared data analysis, and a commitment to sustainability. And part of the reason that we do this, these best-in-class partnerships, is because we want superior clinical outcomes for the patients we serve. We want to decrease variations in care. And from a business perspective, because healthcare is a business, and that's okay, as long as the dollars aren't the thing that drive everything you do, you need financial stability so we can be around to take care of patients. I think we shy away from talking about that, and it's important. So finally, this final slide that Pam had put together, just as a reiteration of what she talked about yesterday, which is creating a learning health system, and Julie mentioned it at Intermountain Healthcare. I mean, that's really what we're trying to achieve. And so I'll finish the talk with a slide that I like to use fairly often. You don't have it in your deck. Big fan of Calvin and Hobbes. And so here's the question that we should be asking ourselves. But the answer isn't how can I change the world? Quite honestly, the answer is how can we change the world? And you do it by these small steps every day, in and out, trying to work on getting better. And so that's why I'm particularly pleased to be at this conference, because this is a group that gets it. And quite frankly, in the circles that I swim in and Pam swims in, there are a lot of people that you would think get it that don't. And so we can lament that, or we can lead. And so I'm happy to be amongst a very austere group of leaders. So thank you very much, and we look forward to your questions.
So I'd like to add one thing that was in one of the prior slides. Again, as we try to develop this implementation, we really are doing a lot of workforce development in this trial. And we're doing workforce development available to all the home health agencies and providers, as well as to all the nurse practitioners, and we've got workforce development with the primary care. So for every one of these team members, we have developed learning modules, and we are really requesting that they take these learning modules in their communities to do it. So there's a huge workforce development as part of this.
Thank you. Now we'll take questions from the audience. If you raise your hand, then the mic will come to you.
Hey, Pam. Pam, and I guess this is for Tony too. I wanted to ask it of him also. One thing that worries me about these pragmatic trials is, especially in the context of physical therapy, that people have a lot of barriers to accessing physical therapy and following through with it. So, my concern is that we set up this large pragmatic trial, but then 80% of the people never get to the therapist to know whether, what we're proposing worked. So I wanted you to talk a little bit about, the barriers as far as insurance and, just your thoughts on how to improve that, and if there's been any discussion, I guess, by anyone in our profession as far as using what the pharmacy world is looking at now, these what's called insurance value designs, where they actually minimize the co-payments to try to increase medication adherence. And I feel like there's opportunities in physical therapy to do something similar, where we try to get the insurance companies to drop the co-payment and some of the cost sharing to hopefully improve adherence and get these folks to the therapist and staying.
So you should answer the question because honestly, Janet has been leading the effort with this group to really educate. We have whole modules on access to therapy services, and we're also educating the primary care providers about this as well. So access to physical therapy services is a real challenge, and as part of this, and again, this can all be available to all of you, Janet has led the effort to lay out what those barriers are just to inform providers. And let me just give you a couple of examples, and again, I'm just using home health as an example. There is, in Medicare, we're talking about Medicare right now. In Medicare, for example, there's a huge copayment for Medicare Part B. And most patients can't afford that, and that means that they've got to get back to the therapy services. In home health, there's not a copayment in Medicare Part A. And most individuals, and as I mentioned yesterday in my keynote, even the leading physicians and geriatricians have no clue about this, don't understand what homebound status means. So a lot of patients are eligible for home health services and don't get them because there's such regulatory criteria and fear of prosecution if the physician ordering it makes a misstatement about a face-to-face home health. So they just say, well, I don't want to go down that burden. So these are real problems. In this pragmatic trial and with Janet's ultimate analysis in the Medicaid and shared health care plan, we will be able to look at how access could be a barrier to some of the outcomes. But it is a true problem. In the state of North Carolina, stroke can be exempt, but you may get 3 therapy visits under Medicaid in 1 year for any one condition for physical therapy. That's a big barrier. I will tell you, being on the front lines, and again, having to deal with home health agencies across our spectrum of care, home health agencies get, their Cadillac patient is the Medicare patient. They get the highest reimbursement rate. But when they come in with managed care, Medicare, they don't want to take your patients. And you know what they do to say they don't want to take your patients? Well, I don't have the staff to deal with them right now. And all of a sudden we started looking at it, well, why don't they have the staff to deal with a managed Medicare patient when they'll take the Medicare patient? That's their business passive ploy to get their case mixed for a more favorable financial reimbursement. Now you can say, well, aren't home health agencies unethical? But just read the newspaper today. They're expecting another 1% cut in reimbursement. So there are just a lot of perverse incentives. But with Janet's leadership, we're trying to educate, and again, we'll make all these available to you because you're not in the North Carolina market, to get providers to understand this as well. But our agreement with the home health agencies that are coming to the table with us, Compass, for 1 year, we send you the patient, you will treat them. And why will they do this? Because we're going to bundle payments, and they've got to figure out how to operate in this environment. As I call it, it's a year of paid R&D for you to figure out how to collaborate for the future. Some get it, some don't. Some send their sales task force, and some send the Richard Hobsons of the world.
So I'm going to add 2 quick things, and Pam keyed up one. Is, as a partner, we feel a moral obligation to take the same payer mix that you take. Right? So Medicare is a much better payer for us than anybody else, but we've always taken a mix. Our mission says to serve millions and millions, not millions of Medicare providers or patients. And part of the reason Medicare is better is they pay you more, and there's actually less burden, believe it or not, because of pre-authorization and so forth. So I get that, but when we work with a hospital, we basically say, if you're whatever your mix is, we'll take exactly the same mix. We do that for 2 reasons. We think it's fair, as a partner, but also so no other agency takes the Medicare and we get stuck with all the non-Medicare. That's not fair either. And so that's the agreement. You have to have that conversation right up front. The other thing that I'll add to that is we need to get the payers to stop looking at utilization outside of anything else. So one of the things the work in PT intervention or therapy, I'll say PT and OT in home health, we're under tremendous scrutiny because we're overutilizing therapy. But they're not looking at it in the context of what are the outcomes. And in some cases, we don't have good data. So in many cases, that's partly our fault. But if you look at MedPAC and you look at the sectors more specifically, home care is in the targets because we're overutilizing. Well, isn't that what you want? Aren't you trying to move people out of institutions? But it's so frustrating that it's whack-a-mole. So I spend a lot of time talking to payers to say, we are perfectly aligned. We want the same thing that you want. Spend less and give better care. And we can do that if you can take off some of the shackles.
So to follow with what Mike said, PCORI, we personally, you've heard it over and over, the most important outcome for the patient is a functional status. The most important outcome for the payer is that you decrease the long-term trajectory of functional decline and decreased skilled nursing placement. The payers don't care that much. Medicaid cares about that. The payer really doesn't care about SNF placement because they don't have to pay for it, right? But to them, if they have more hospital readmissions and more intervening falls and fractures and things like that. So you've got to look at your policy implicated metrics as well. That's going to convince the payers.
Okay, do we have another question?
There got to be questions. Are we over? Are we early?
I'm counting on Tamara to keep us on. One more
Okay.
question. All right.
I was hesitant to ask another question, but I'm wondering how outpatient PT fits into your model, Pam.
Totally same. The outpatient therapists are part of this whole integrated process as well. And what we are encouraging the outpatient therapists to do is some of the work, trying to build on some of the great work that Kelly and others are doing. You know, do you need booster? You don't need, educate, get them exercising, get them in the falls prevention, and then provide them booster models and trying to work with them to think of it that way. But outpatient therapy is very, and Janet keeps reminding me every day we talk about home outpatient therapy too.
And I'll just jump in to say, for us, that's also very important because Medicare Part A and Part B were designed as a continuum.
Yes.
So we look at how do you make sure the patient is able to maximize that benefit to maximize their function. So for us, it's the world doesn't revolve around Part A. The world revolves around how do we get that patient the care they need. So we look for partners in Part B therapy clinics in the community that we trust, even outside of the Compass Project, so that we have this place to refer to. But when we're finished with them, they're not fully baked. The benefit wasn't designed to do that. It was to sort of right the ship and then move them along. And so for us, that's a really important part of the continuum.
So one other comment, I think it goes back to how do we, you've heard just fantastic presentations. And if I were a novice sitting in this room, I'd say, I couldn't possibly do this, right? It can be done. And, a lot of it is about leadership and aligning leaderships both from the bottom up and the top down. And sometimes you use the carrot and sometimes you use the stick in order to do this. But the most important thing, we have to be transparent in purpose and goals. And what's disappointing, and I'm not talking about just this product or this compass, but when I sat in the C-suite for 3 years, it was the best learning experience of my life. It was also sometimes the most discouraging moments in my professional career. Because I see that the health systems are under such stress. And the health system, the academic medical center is, oh my gosh, I got to reduce readmissions and give me the current McDonald's meal to do it. Well, it's not that easy. And so we have to be able to invest in the long term, not for the short term response.
So I
And
think
only then will we transform healthcare. But it takes patient, diligent leadership, sometimes a carrot and sometimes a stick. And
I'm sorry to interrupt the discussion, but we have the next speaker
Okay,
panel.
thank you.
So we thank you very much for your presentation.